And I always say that there's maybe 1% of our population, maybe less, that are what I call the true caregivers, much like yourself. I mean, this is a gift that was given to you. You were bred with it. And then, but it's even beyond that. It's a true gift.
Yeah. And I think you're an operator as well. You know, the people that intuitively have it and the ones that try really hard and just don't. But I think at the heart of it, it's looking at people as people, not as tasks, and really somebody that wants to impact another's life. Those are the people that show up today when it snows, right? There are people that look at the weather and call in on Friday before a storm on Monday. And then
because I can call in and still have an excuse not to show up.
It's not even snowing yet. I'm calling in because it might snow and I'm forecasting I'm not going to be able to be there. And there are people that would take a cab, an Uber, have a brother pick them up, have a brother pick them and their coworkers up that will get there. Those are the people I want to surround myself with. Those are the people I want to create a business model around, because those are the people that get it.
Will you still need me? Will you still feed me when I'm 64?
And now the podcast where together we discuss proactive aging on your terms, connecting to the professional advice of our special guests while creating better days throughout the aging process. Now here's your host, Mark Turnbull.
Hello, everyone, and welcome back to another lively discussion on aging today. We are the podcast where together we're exploring the many options to aging on your terms. You can find Aging Today and our past 8 years of programming on our website. All you got to do is dial into agingtoday.us. And I just want to say thank you, all of you that have been following us. And if you haven't started following us, please click the follow button and begin following us, because we have so many great guests and conversations on aging today and the whole process to what it means to age. And that is no different for today. In fact, I do know one thing is for certain. They used to tell us that two things were for certain, and that is death and taxes. I know that there are people that avoid taxes, but I don't know anybody that has avoided death. So there's only one thing that you cannot avoid, and that is death. And that's what we're going to be talking about today. We're going to be talking about the type of life that you want to live as you approach the last chapter of your lives. And here to join us in the conversation and to lead us into that is Stacey Zerban, and she is the Vice President of Health Services at the Friendship Village. And Stacey, I'm delighted that you're on, and especially today because it sounds like you guys are snowed in.
Yes, we are snowed in, but if you're in healthcare, you're never snowed in, right? So, the show must go on. And so we're here. It's a little colder than when I left work on Friday, but nonetheless, we're here and excited about the conversation.
Yeah, me too. And it's near and dear to my heart. I know that you've been doing this for a number of years. We have as well. We own an in-home care agency and a hospice agency. So I am delighted to have a conversation with a fellow sojourner along the road. And today, we're not going to just talk about hospice, but we're going to talk about the new vision, the new way of looking at hospice, and the way that hospice really is meant to be. That's where I hope that we can go, and not a traditional conversation. Are you in?
Right. I'm all in.
All right. Sounds good. But before we do that, we always like to hear from you. What's in your story, and where were you brought up? What did you want to do with your life? And then how did you end up where you are today?
Yeah, sure. For me, I was raised in long-term care buildings. My mother was a registered nurse for 50 years. The majority of that time, she spent being a director of nursing for several nursing homes in the St. Louis area. So when most of my friends were going to the beach on spring break, I was alongside my mom, volunteering in activities, calling bingo, and really just felt automatically in tune with the elderly. I knew very young that I have to do something with the senior population. And so I went to school and studied, graduated with a communications disorder degree. And back before Medicare was what it is today, I was told that you really are going to only work with kids with a speech therapy degree. And quite frankly, at that age, kids scared me. They still scare me to some degree, but it just wasn't the space in which I envisioned my career to be. So started right out of college as an activity director, just kind of getting my foot in the door in a small facility in Springfield, Missouri, and then slowly started to, take advantage of other opportunities that came my way. Was a nursing home administrator for 20 years, 6 of that at Friendship Village, and then later became the vice president of health services for Friendship Village.
Yeah.
So that's
How
my
is
story, the family business, I guess.
Yeah, absolutely. How did that impact your life? You mentioned that while everybody else was going to Disneyland and developing their own Disneylands, and you were going to senior centers with following your mom.
Yeah.
What kind of an impact did that have on you?
Well, I mean, she was the general. As far as I saw her, she really taught me at a young age where the bar needed to be as far as taking care of people, what compassion and empathy looked like as a young person, taking care and spending time with seniors. And I believe that's kind of a trait I've been able to pass on to both my children now. One's a freshman in college and wants to go into the healthcare space. And the other one is the big teddy bear who loves to be around seniors. And so I feel like empathy and compassion is not something that people automatically have, but we have to kind of put them in landscapes in which they'll be exposed to different things because, not everybody has grandparents. Not everybody sees their grandparents, but, in any given facility or senior living community, there's 500 potential grandmas and grandpas that you can show love to. And the love you get back, I think, is tenfold. But for me, it's always been a personal journey, really holding my mom with the highest regard as far as keeping me on point, making sure I don't personally accept less than, because she would not be happy. She'd be looking down at me with that look, and you don't want that look from my mom. So, for me, it's been always a personal journey and really just working the way that I saw her personally work and the way I think she would expect me to work today.
Yeah. Do you see this as a calling for you?
Yeah, for sure. I do. I think
not a job, not a place for a paycheck, but a calling. What does that mean to you?
Yeah, I think it's what you just can't get away from, right? So it's a calling is just what you think of in your spare time. I mean, I think people that are really invested in their profession and in their callings never take a break about thinking how we can do something better. I mean, I'm always kind of challenging myself or talking about, well, what about this? Or I don't like this, or why is it like this? And just trying to continuously push that bar higher. And I think I can't imagine doing anything else. If I won the lottery, I would still want to do exactly what I'm doing. Maybe a little differently. But if you had money to impact a lot of things, that might look different. But certainly, I don't think I would ever do anything different with my career or my career path.
Yeah.
No.
And you've probably come across a lot of people who consider themselves or have tried out being a caregiver. And some get it, some don't. And I believe that all of us have that capacity to care for another human being. But to do it on a professional basis, day after day after day after day, to complete strangers, that's a whole nother level of a caregiver. And I always say that there's maybe 1% of our population, maybe less, that are what I call the true caregivers, much like yourself. I mean, this is a gift that was given to you. You were bred with it, and then, but it's even beyond that. It's a true gift.
Yeah, and I think you're an operator as well. You know the people that intuitively have it, and the ones that try really hard and just don't. But I think at the heart of it, it's looking at people as people, not as tasks, and really somebody that wants to impact another's life. Those are the people that show up today when it snows, right? There are people that look at the weather and call in on Friday before a storm on Monday. And then
because I can call in and still have an excuse not to show up.
It's not even snowing yet. I'm calling in because it might snow, and I'm forecasting I'm not going to be able to be there. And there are people that would take a cab, an Uber, have a brother pick them up, have a brother pick them and their coworkers up that will get there. Those are the people I want to surround myself with. Those are the people I want to create a business model around, because those are the people that get it. And you're going to be successful when you surround yourself with people that get it and are like-minded.
Yeah. And it creates a lot less stress in the long run when you have people like that. And my grandfather always told me, he said he was a successful businessman. And I said, what was the reason for your success? And he said, oh, it's easy. And he pulled out his tattered little saying, and it said, never be associated with failure. And what he meant by that was surround yourself with people that are better than you or that are gifted, that you don't have to, spend a lot of time holding their hand. They just are driven. They get it. And that's what he did. And that's what we're attempting to do as well.
Yeah. And that makes the job fun, right? And that makes doing things like this fun.
Yeah.
Because you're around people that look at it as not hard, but it's a privilege, and it's an honor to take care of people. And when you're around that every day, that's infectious. And so that's exciting.
Truly is. Have you ever stopped and pondered about what is the definition of a caregiver? Because I believe it doesn't matter if you're an owner or if you're an RN, a doctor, a CNA, just a regular caregiver. I mean, you don't need a degree.
Right.
But what is a caregiver? You ever thought about what are the traits, that you've noticed about those people?
That's such a great question. I joke that I'm not a nurse all the time. So, but to your point, I'm a caregiver, and all the important stuff I think I can do. The gifts of patience, kindness, human touch, the gift of giving time, where you're not always looking at your watch because you have to move on to the next thing. I think, and really having the gift of being interested in who you're serving, because they all have a story, right? And if you just are trying to figure out, like, tell me, what is something deeper about Mary Smith that I can maybe connect with, that brings light and joy to her life and makes my job, which the jobs are hard. We're asking people to do hard things. It can also bring joy to them. So I would think all those things are important.
Yeah. I think curiosity is one of my favorite words, and you have to be a curious person. And what is it that makes Stacey tick? Who are you? And when you are a caregiver, you should be able to walk into a room and begin to take a special interest in that individual. I always tell my caregivers, think of yourself when you're a host of a party. What's your role at that party? Your role is to wander with your eyes all around the room to make sure everybody is comfortable.
Yeah.
And that's a true caregiver. And I came up with a definition, and I want to throw this at you to see what you think. But a caregiver is someone that can spontaneously recognize the needs of another person and act upon it.
I think that's spot on.
I mean, it's just like, wow, spontaneously recognize, that takes awareness, that takes a presence. And I think so many caregivers, as I watch caregivers, some get it, like you said, some don't. Those that get it are present.
Yeah, and just being aware of your surroundings and connecting the dots, right? And so, like, when you enter a room and you're like taking care of somebody, noticing things, noticing pictures, noticing books, maybe noticing that their water, they can't get to it. It's
Yeah,
all the little things. It's all that, like, just being aware of your surroundings and connecting the dots so that you can do better for them. I
yeah,
think it's huge. Yeah,
yeah. Finding ways to make their life more, easier, finding their ways to make their life more pleasurable, more
exactly.
comfortable, all of those things that go into that. And then I've noticed that there's different types of caregivers. There are the caregivers that are really good with companion care, but they may not be so good with personal care. And then there are what I would say that there's many caregivers out there that are more transactional as opposed to relational.
Mhm.
Have you noticed that as well?
Yeah, for me, transactional caregivers, I'm not a fan of necessarily.
Yeah.
You really wouldn't want transactional caregivers orientating any of your new hires because you're just going to breed more transactional caregivers. Um, I'm always
Explain to our audience what we mean by a transactional caregiver.
sure. So, what I would say that kind of goes in lines with is like just looking at a person at all the tasks that they have to do for
Yeah.
them.
Yeah.
And so, for instance, if you walk into a room, you're looking, well, I have to bathe Mary, dress Mary, change her clothes, clean her room, make her bed. Those are all the things that go with taking care of Mary that day.
Yeah, they're
Um,
transactional. They
it's
are
transactional.
every
Mhm.
relationship has a transaction to
Yep.
it, but what is the motivation behind that transaction?
Yeah. And I think it's just to get done, and
Yeah.
just to get done the quickest. And when you have a transactional, can you imagine being on the other end of that? Where I mean, usually it's pretty obvious that you have a transactional caregiver. They don't talk as much, they don't engage as much, they don't make eye contact as much. All
Yeah.
the fluff things you don't get. I would much rather have the slower relationship type of caregiver because that's what's going to be so much more impactful for the residents that we serve. I've had residents tell me when I was an administrator, I had my aide walk in 4 times and she did all the things great, but she never once said hi. She never once asked how my day was. She never once, asked if I was in pain. To me, that's a failure. Even though her care was spot
Yeah.
on, the important things that are going to make her feel like I chose the right place, those were not present that day. So having somebody that's on task and is going to do all the things, but also can be human when they do them, that's the optimal employee that we look to have.
Yeah, absolutely. And then there are those caregivers that not only are maybe gravitate more towards companion care or personal care, but then there's hospice care, another type of care. What kind of a caregiver? Because I've got some exceptional caregivers that are in those other two categories, but when it comes to hospice care, oh my goodness, not for me. And they go the other way, which is fine.
Right.
There's a place for everybody. What kind of a caregiver is a hospice caregiver?
So, I mean, I think they have to be really comfortable with the death and dying process, number one.
Yeah.
And they have to be comfortable in their own skin so they can make somebody be comfortable that they're taken care of. I think that's number one. Number two, really sizing up the room in which you're doing care. You're really trying to make sure, a lot of times families are present. A lot of time you're going into somebody's home, really just making sure that that resident has everything they need, whether it's an electric hospital bed, whether it's a wheelchair so they can get up and maybe play cards with their grandchildren. Making sure all their pain medicine is in so that they never have to go without a pain, medicine. I think they have to really size up the room and look for potential issues that may come, and be totally proactive in that. That would be the one thing that I think is often forgot about when we train our staff, and we do both in facility rotations and in the homes. We tell them that you're the eyes in that home for the day. Tell us
Yeah.
what you see. Tell us, ask our patients how they're feeling. Is it, is all their needs being taken care of? Can we do anything that we haven't done yet to make, your day better? And then, all of it still goes hand in hand with being compassionate, taking our time, communicating appropriately, both with the patient and the family. All of those things, I think, really help us give really great care at the bedside.
Yeah, and that's going back to the role of a caregiver is to observe and report, and just exactly what you were describing. What is it that I'm observing? What is it that I'm reporting back? And it's with the goal of, creating a better day for your patient.
Right,
And
exactly.
that's the bottom line, whatever
Right.
that means to them.
Yeah, it's meeting them where they're at and trying to make sure that anything in a very, what seems to be uncontrolled time in their life, that
Yeah.
we can bring some control back to the patient and really try to make sure that anything they need, want, or desire, we can get for them.
Yeah. And today we're going to focus on hospice care. We're going to talk in specifics about that. And I really want to start just with some of the basics. What is hospice care? And I think there's so much confusion out there. And in relationship to palliative care.
Sure.
And so maybe we can kind of lay down the definitions, if you will, because as I understand it, palliative care is used twice. It's used as an umbrella term, but it's also used as a specific type of care. So explain that to our audience.
Sure. So palliative care is when you have chronic diseases, and by that, an example might be COPD, CHF, that there's no cure for. So it's really an approach to those diseases, how aggressive, how passive you want to be, giving yourself kind of an advanced care plan, sitting down with, your family members and talking about what right looks like in treating that disease. When don't you want to treat it anymore? Palliative care can be hospice, but hospice can't be palliative care. So palliative care is those first initial conversations with the patient, the physician, family members, when there's a new diagnosis or when a diagnosis is just being a little bit more cumbersome to deal with. Maybe there's more frequent hospitalization. Maybe medicines that were working aren't working as well. It's really that conversation and that discussion about what does right look like when we go and we treat that chronic disease. Do you want to go back to the hospital? Do you want to, in some cases, have chemotherapy and radiation? Maybe the other 2 times didn't work. And so do you really want to do that again? Really also, and you and I kind of talked about this briefly, it's taking the time to really educate the patient and the family about what these diseases look like in today's state, and then what will they look like as they progress. I think we all know that our primary physicians are very busy, and those office visits are very busy. 15 minutes is the average that a primary doctor spends with their patients. It's really hard to have those heartfelt conversations in 15 minutes. Where you can really have some dialogue back and forth and get people to really start asking themselves questions, or maybe, daughters or sons start talking to mom and dad a little bit more real, like, okay, how are you going to stay in the home by yourself if these things continue to be progressed? Or do we have a plan in place? Even as broad-scaped as do you want to be a full code or do you want to be resuscitated? Having those conversations before chaos is always the best time, but sometimes those important conversations don't happen in the physician office like you might think. And so I think that's when palliative care can be super, super helpful, to have a practitioner that works with the family, visits the family, monitors how that disease is progressing, and continuing to educate that family. I think palliative care is awesome, and I hope to see it used more because I think it really can alleviate a lot of chaos and confusion down the line. When we talk about hospice, that's a little bit more defined. Hospice is a doctor, actually two doctors, a primary doctor and a hospice medical director. Both say, okay, we're looking at the movement of your disease process. And we both agree that if it moves in the normal medical textbook way, that you have 6 months or less to live. And so that is certified by two medical directors, and then you would be eligible for hospice services. And hospice services, did you want me to explain that part, Mark? Or
Oh, sure. Yeah,
okay.
absolutely. Because I think there's a lot of confusion as to that and why a lot of people don't. One of my biggest pet peeves is that people wait too long to get onto
Amen.
hospice care.
Yeah.
And eventually we should need hospice care at some point, but many people miss that opportunity to have those services and take advantage of those services, and they're all paid for.
Right. So
for the most part.
Yeah, for the most part. And I will say this, we both have talked about what people think hospice is.
Yeah.
And through this journey of creating a hospice program for Friendship Village, I've had even friends of mine say, well, hospice is, you just don't feed them anymore, right? I'm like, no, they can eat whatever they want, in fact. Well, they're just going to starve to death. No. Oh, so they're going to die right away. Once again, no. So there's a lot of really negative outlooks on hospice. And just that word, it is just really, that word makes it hard to even break through the wall to even have further conversations. So palliative care allows us to kind of have those conversations a little bit easier. Those walls are kind of down for a little bit. But hospice care is a great benefit. It's paid for by your Medicare benefit if you're 65 years or older. Obviously, commercial insurance plans have hospice benefits as well. And if done correctly, you really can set the table for a real quality, dignified passing of your loved ones. We always want to get in as soon as possible because we want there to be ample enough time to talk to the chaplain, people to plan their own funeral in some cases, or celebrations of life, which is big on my books. I don't know why we wait for a funeral to celebrate somebody's life. Why can't we celebrate them while they're living? It's not a really new idea, but something that, I feel like we should challenge that a little bit more, because the people that are being celebrated want to see all those people show up. Sometimes they haven't seen those friends for a long time. And so, hospice care gives us the ability to provide a nurse, a chaplain, a social worker, a personal caregiver. We have a medical director that oversees their care as well. Volunteers, specifically for us, that's been super impactful here at Friendship Village. So it gives us a nice amount of time, if done right, to really get in there, dispel the rumors, and that's through consistency, and making them feel like the sky's not going to fall down. Sometimes there are imminent passings that occur really quickly, but ideally, you would want enough time to be able to really bring in the services that make hospice a really special program. And so most of the people that we do palliative care visits on are appropriate for hospice when we do them. So most of the hospice patients we bring in probably would have qualified 6 months prior to enrolling them. So education, and not only to families, but certainly to practitioners and physicians, to really look at, the diagnosis, lab results, and really look at, this person's been failing. And sometimes they only look at them how they are today. But if you look back for 3 months, they've lost 25 pounds. They're not doing well. And so really there's just a lot of education, a lot of conversations that need to be handled around the kitchen table about how we want to live our last months, days, or years. It's really super important to have those.
And I think it's important that you mentioned years, and I know that many of the patients that we've cared for can last a year or two.
Yeah.
The most famous case being, our president, Jimmy Carter, and he was in hospice. What was it? 12? Was it 14 months?
Yeah,
something like that.
I actually have the article. It's on my desk, and it's his quote to say, "Hospice is not giving up."
Yeah.
Think about that. Come on. That's awesome.
Did you know that over 1.7 million people access hospice care each year, and their average length of stay is 70 days? Most people have a preconceived notion about what this kind of care means, but Stacey Zerban says it's time to rethink the negative connotations. We need to focus on the experience of living. We need to empower people to have the conversation before they need care so they can make their own choices and remove the stress from family members so everyone can focus on their time together. We should help them celebrate their life and celebrate the care and love they receive. Learn more about Friendship Village in St. Louis and call today at 314-270-7700. This Did You Know moment is sponsored by Royal Hospice Oregon.
Yeah. And there's a lot of negative attitudes towards hospice and that we're trying to overcome. And it's difficult to overcome some of the stereotypes that are out there because a lot of these stereotypes are not being addressed by the medical community and physicians in particular. And sometimes I feel like a fish swimming, upstream. And it's not an easy road to change the paradigm on how we look at hospice. And we don't need to look at it as a death sentence. In fact, I think, and I think you're in agreement because when I was reading some of the things that you wanted to talk about I lost you there for a minute, was that, hospice isn't about how you die. It's about how you're living. Comment on that.
Yeah, that's really kind of our mission is it's not about focusing on the end game. Because as you said earlier, we're all going to go there. We all have the same end game. It's the one thing that connects us, unites us.
Yeah.
And whether we like it or not, we all have that in common. And so what is different is how we live. And hospice services is only going to bring more life, if that makes sense. We think about hospice as so many families, as soon as they sign paperwork, they're really vigilant, for like the first week. There are lots of visitors sitting by the bedside because in their mind, they're dying in 1 or 2 days. And so when we show them that through different interventions, different complementary therapies that we offer, music therapy, massage, our volunteers, and just actually more care, people start to feel better. They start to eat more. They start to, participate in conversations that maybe they didn't or weren't able to before. And there are some cases that people graduate for hospice. We have 2 graduating this month. That's a success story.
Mm-hmm.
That means that
when you say graduating, what does that mean?
So when we have our team meetings, which is every 2 weeks, we are looking for hospice appropriateness. And so we are looking.
And who sets the stage for hospice? So
our medical director and their primary.
Yeah, mm-hmm. but who holds you accountable to that? Medicare.
Mm-hmm.
Yeah.
And so we have to, turn in all of our documentation, et cetera. And so sometimes, and COVID was a perfect example of this. There were people that had COVID and took a very, very, very big decline. And so a lot of families, a lot of doctors said, okay, come in with hospice because we don't think they're going to bounce back. And so we bring our services in, and with time in the right level of care, in the right services, they are able to get their strength back. They're able to, take in more calories, and they're able to get a little bit better. It does take time for that. But, sometimes a doctor might say, yeah, this is the trajectory that this person is on. I don't see them, changing, so they're appropriate. But then there's only one man upstairs that really knows when your time is. And sometimes, when we look at the patient holistically, the whole patient, we realize that, oh, they're not losing weight. They're not asking. They're not in any pain. Their labs, they're actually stabilizing to the point that they're no longer hospice appropriate. And so we will then take them off of services and monitor them from a palliative care perspective moving forward.
Yeah.
So we do graduate people. We do graduate people from hospice because, sometimes, the body is an amazing thing that when it's given enough time of healing and the right people around them, they do get better, or they stabilize to the point that they're no longer qualified for hospice.
Yeah. The other thing too is that, our healthcare system is in such disarray, and it takes 2-3 weeks for mom, dad to get an appointment to go see their primary physician. And they are, they're declining, whether they're weight loss and on it goes. And it goes to show why people, either graduate from hospice once you put them on hospice, because now all of a sudden they're not having to get in the car, go down to, 3-4 weeks after a symptom has developed to get the attention from their medical doctor. With hospice, you get it immediately. You get it that week.
Right. And, we go out often. So if there's any decline, we're there. We do daily visits. We up visits to 3 times a week if we need to. We're really monitoring those changes of condition, and some are long lasting. And they indicate that somebody might be transitioning, or it's just a little bump in the road and they get over that hurdle and it's, they're stabilized again. So I think extra eyes are always great eyes. And I think too, back to the practitioner, it's not their fault to some degree, because it's just the way that the business has changed for those doctors.
Mm-hmm.
It's just that they usually are interested in solving problems. So when you go to a doctor, unless it's your physical or your routine appointment, you're there to solve a problem. And so doctors get in that tunnel and they solve that problem, and that patient is good till the next problem occurs. And then that problem comes and they solve that problem. But we don't see a lot of holistic practicing, meaning have we looked at how many problems and how frequent the problems are occurring to really then be able to get a better picture on how this person is doing.
Yeah.
If I look at my weight for today, it means nothing. But I look at it for the last 6 months, it may tell a different story. And so I think that sometimes in this busy, busy world where these appointments happen and we have to get them in, and, hospitals aren't what they used to be either, that we've got to slow down and really look at these people holistically to be able to forecast and help them in the best way.
Yeah, absolutely. And the other thing too is that doctors, like you said, they're in a curative mode frame of mind, and and a lot of times seniors, when they do go in, I've seen this with my own parents, I've seen it with others that we care for, when they get in front of a physician or a medical professional of any kind, they always paint a better picture than what's really going on.
Yes. I have an 86-year-old father, and I go to every appointment because of that, right? They're always given best case scenarios. They're, painting a picture because they don't want anyone to think they can't live where they're at. They can't be independent. So I do think that's valid. And so I always preach to children of seniors is that they've got to be involved. They've got to be an advocate for their loved ones, because otherwise they're going to get really missed and they're just becoming a number at that point.
Mm-hmm. And then when somebody is considering going on, maybe it's the adult children of mom and dad that are considering hospice,
Mhm.
and they have to get over that fear of bringing up the H word, right?
Right.
Okay,
Right.
so how do you have that conversation with mom or dad, because there is that stigma that is out there that oh, you mean I'm going to die if I have this conversation? I'm a hospice operator, and I had that fear with my mom and my dad, especially my dad. And I had to have the conversation with them and explain the whole process of these are additional services that are going to help you live your best life possible. But there's some caveats to that. Like, you have to give up going to the hospital. You have to give up. There's some things you have to give away.
Yeah, I can remember having the most specific conversation with my mom. Here's a nurse. She's been to the hospital with COPD for every month, and every visit gets worse, and it takes longer to get out of the hospital. And for me, I just kept seeing a more exhausted version of my mother coming out of the hospital. And so really just to talk to her in the context, call it anything you want to call it. But it really gets down to the why. Do we know why we're doing this, Mom? Do we know why? How are you want to go to the hospital? You've been to the hospital 3 out of the last 4 months. Do you want to be on oxygen? How can I, as your daughter, as your advocate, help you live the life you want to live? All things considered with your diagnosis. That was hard. That was
Mm-hmm.
a little bit, that was not something that I was really trained or prepared, or there was really no in-service for that conversation. A lot of times
Do you
also,
think, Stacey, do you think that it's harder for you than it was for your mom? Because I
that was the
often,
point. Yeah.
I want to, because I go back and it was harder for me having that conversation with my dad than I think my dad was in hearing it. But you do have to use the right verbiage. Like,
Right.
okay, Dad, by being on hospice, one of the myths that you talked about was, oh, being on hospice means you stop eating, so you can't feed anybody anymore. No, that's not hospice.
Right. Yeah. So sometimes I think for residents understand, if they're of a later in age, and obviously there's always more horrific stories of younger people and, different circumstances. But if you take your basic 84-year-old senior, they've had people pass away. Death is not new to them.
Yeah.
They've lost friends. They've lost maybe a spouse. They've lost family. They're still going to protect the children from the thought of losing them. They're still the protectors. And so I do think there is this kind of yin and yang where the daughter doesn't perhaps want to have that heart to heart with mom, but the mom doesn't want to leave the daughter. It's that kind of thing. The mom knows where they're going, and the mom, sometimes they miss their spouses so much they want to be reunited with them, right? And so, but they don't want their children to be in any pain after they're gone. They're okay with the plan. They're okay with hospice. And I always say that, my mother is in a better place. We might not be in a better place without her, but she for certain is in a better place without the suffering and having the hardship she did with her own personal disease process. But I do think parents always still try to protect their kids from that pain.
Yeah.
And so I do think that's why you see people wear when you look at their records, it doesn't make sense why they continue with chemotherapy or radiation. Everything basically says that these things are no longer curative. But if you ask them, it's, well, my daughter wants me to keep doing it, or my son, doesn't want me to give up. And so you see kind of that yin and yang. And so, boy, advanced directives are pretty helpful at that point to refer to and just kind of talk about what they wanted for themselves before there was this crisis or this big decision that needed to be made. But I agree that those conversations are tough. But I think once you just start peeling back that onion and really focus on how you can really be impactful from a quality perspective with your hospice program, I think you get there, and you get there well.
Yeah. The other thing too is that I think we don't give enough credit to mom and dad for, they understand and know their situation probably better than we do. And they're just grateful that you took the time to acknowledge that, so that takes a little bit of the pressure off of them having to have this conversation with you.
Yeah, it's almost like giving permission to be okay to pass away.
Yeah.
And how many times have we, around a bed when somebody's in their final moments, have said, why is this person hanging on? Why is this person hanging on? And really it's that permission to pass. And, I think my goal would be, let's have those conversations ahead of time, so we're not at that point, right? Let's have these open conversations, like, these are the disease processes, these are the treatment options that we have for them. Where do you want to go with them, Mom? Where do you want to go with them, Dad? And really have those at a palliative care level, so you're not trying to give somebody permission at the bedside in a very imminent stage.
Yeah. Yeah. And sometimes it's easier to have those conversations when there is a life-limiting, illness or disease. But a lot of times, my mom is a case in point where she doesn't have any long-term chronic illnesses or diseases, but she's 95 and, the engine's burning out.
Yeah.
So we made and then she's been falling, she's been losing weight. And so talk a little bit about how to have that conversation with when the fuel is just running out in the body and the body's just saying, I'm tired. And so we took, and she had chronic, the biggest thing she had was chronic UTIs.
Yeah.
And she looked at me the last time she went to the hospital and they put her on IVs, and she says, I'm done. I don't want to do this anymore. She knew, and I said, okay, well then there are some additional services that we can provide you so that you don't have to, Mom, come back into the hospital or go see the doctor and wait another 3 to 4 weeks before you get in. And let's consider the hospice services. And she said, okay.
Yeah. I mean, I think they do always say, I'm tired. I'm just not what I used to be, or, things aren't as easy for me as they used to be. And I think, as we tell our caregivers, right? Kids are caregivers. Be aware. Those are introductions to a bigger conversations. And in fact, you could look at them as gifts, because they really are cracking that door for a bigger discussion without you having to bring it up. But you can certainly dive in to say, well, tell me more about that, Mom. You're tired. What does that mean? Are you just, is it harder for you? Are you struggling? Maybe let's see what we can do so it's not so obtrusive for you anymore. Let me use all my contacts and see what we can do to make things a little bit easier for you. I think a lot of people say that to their kids. And then I think a lot of kids say, well, Mom, you're fine. Everything will be fine. I'm tired too. But really, we need to use those little things, those little nuggets, as gifts, because they're really telling you, I'm there.
Yeah.
And I need help, and I need you to be okay with it. And I think that is so huge. And that's why I think I'm such a really proponent, not only, as I think hospice is such an amazing thing that we can do for people that we love. But that palliative care conversation sure sets the table for those deeper conversations. And the hope would be you start having more of those palliative care conversations. So you're not just waiting for somebody to tell you they're tired or they're kind of done, And so I do think they go hand in hand. And I hope more and more people are just open to learning more about both.
Yeah. Yeah. The other thing that we noticed with my mom's health is that once we did put her on hospice, we went through her regimen of medications, and she had very little compared to most seniors. And I think she had maybe three medications, and then some, occasional Tylenol or, some vitamin E and all that kind of stuff, But the one medication in particular was a memory medication. And I always said I'm not a huge believer of that stuff anyhow, because there really isn't a medication to,
Right.
correct somebody's memory. They're usually there are other medications that were used for something else. And when we took her off of those medications, her UTIs improved. So maybe, not always, but maybe the amount of medications that if you've got a loved one that is experiencing a lot of UTIs, it could be that the medications that they're putting into their bodies is what's tainting the well.
Well, and this goes back to, what I would tell a friend that's a daughter or a son to somebody. Get involved. Start looking in the medicine cabinet. You will be amazed at what they keep and
Yeah.
what they're taking. And we don't have a healthcare system that speaks to each other, meaning everybody comes out of the hospital now with a specialist, and every specialist prescribes different medicines. And not all the doctors talk to each other to say, well, does this make sense? Or why are we doing it?
Yeah.
And sometimes there's interaction. I mean, there are some people that are on 20 medicines. They're 99 years old. What? And so we really have to continuously, pro versus con, risk, reward. When we talk about these medicines, your mom was falling. I would go to medicines right off the bat, as I'm sure you did, and say, is there anything in this in this list that could be contributing to that? And so
Yeah.
you solve the UTI problem. You also probably solve the fall problem. But these practitioners, because they don't have a system to speak to each other and to stay in the loop with each other as much as we think they should be able to, we've got a lot of different people prescribing a lot of different things, and there's drug interactions. And sometimes removing some of those, people feel better.
Yeah. The other thing I want you to comment on too is that one of the myths that is out there with hospice care is that individual needs to be bedbound. And there's this idea, it's kind of like with the stop eating type thing, but it's, oh, you can't walk around. You're too healthy for hospice care. And my mom's been on hospice for, about 4 months now. And her life just keeps improving. I mean, she is declining. She is losing weight. She is, she's all the traditional things that go along with the body declining. Right. But we try to keep her as mobile as we can, because think of it in terms of you're helping somebody to live their best possible life with a quality of life, and the body's designed to move. So if you can keep them as mobile, because there will be a time when she won't be mobile, but if you can keep them mobile and create an atmosphere of living life, the way she has always wanted to live life. And we try to create that atmosphere. I had family members come in and say, well, you can't be taking her on trips to the beach or, oh, yes, we can, because that's where she wants to go.
And we're going.
And we're going. Yeah. And my family is looking at me like, what are you doing? You're going to kill her. I mean, that's the way it comes across. And I go, oh my goodness.
Doesn't that get back to what the picture of hospice looks like?
Yeah.
That the stigma, right?
Yeah.
We think hospice, doctors think this way. I think caregivers to some degree, they're not qualified for hospice. They just went down to the dining room with their walker.
Yeah.
Okay, but that doesn't mean that they have great heart function, lung function. Doesn't mean that they don't have a cancer. Doesn't mean that their dementia isn't it. I mean, so yeah, that just goes to the stigmatism that surrounds hospice, which I think is sometimes why people don't get prescribed or referred for hospice, because they're not bad enough yet.
Yeah. They're not on their deathbed.
They're not bad yet.
Yeah. Yeah.
Well, nothing I'm going to do today is going to cure X diagnosis. Hospice isn't going to cure a chronic disease, right?
Yeah.
Or somebody that's just frail, failure to thrive, all the things. And so, yeah, we've got a lot of work to do. We need more conversations like this to really just say, why wouldn't we want them to be able to go to their daughter's wedding?
Yeah.
Why wouldn't we want them to go to their granddaughter's graduation? Does that mean they're not dying? No, it doesn't. It just means that we have a gift still that we can give her those moments.
Yeah.
And so people get really kind of scared to operate on those guidelines. But the guidelines specifically tell you when somebody can qualify for those services. And we've painted or backed ourselves in a corner that it has to look like something, and it really doesn't. And so I hope that these conversations can help that, because if you could take your mom to the beach, you just gave her the best gift ever, but you got one too.
Yep.
So why should we run away from that?
I tell that to my siblings all the time. Take her, go do things, go do what she wants to do. And they've come around. And because when we first put her on hospice, it was like, oh, put on the kid gloves. We have to treat her now, put her into bed, and say your goodbyes. And the family would come over. Like I think you mentioned it earlier, when you first put somebody on hospice, all the families come over and they're ready to say goodbye. Mm-hmm. Well, in some cases that may be true, especially if the physician and the family has neglected to observe really what's going on and they wait until the very end. Yes. Because a lot of times, another one of my pet peeves is that, people don't get to take advantage of the services because they wait till their last week of life.
Yeah. And we then have a very chaotic situation that we're expected just to go make right in a very small amount of time.
Yeah.
And it's not how it was supposed to be. It's not designed that way. And so I am just hoping that the work both of us do, the conversations both of us are having, starts to change that narrative around hospice.
Yeah.
It's really such a great gift we can give somebody.
We just got back from the beach, and she wants to go back. And so we're going to go back and later this week. And then, and I look at it as an opportunity to give her the gift of life, living the life that she wants to live. And if she dies in the process, then she lived her life. I mean, I'd rather.
What better way to pass away?
Oh, I'd rather pass away in the car or in front of the window at the beach than to be sitting and moping at your own home, saying "woe is me" and whatever else goes through people's minds. No, stay active if you can. Yes. Not everybody can.
Yeah, I think you can't be afraid to have those moments.
Yeah.
I mean, in today's, I think we've learned through COVID and other things that you can get around, even if you're wheelchair bound.
Yeah, absolutely.
There's buses now. There's vans. Get them go share some experiences, you are creating the lasting impression. And that's what I like to think that we create with hospice, is that truly lasting impression. And if we can give a family that with their loved ones, that's a gift.
Yeah.
That is just a gift.
And
And we
plan-
need more gifts like that.
Plan celebrations. Like my mom's birthday is coming up. It's February 28th.
Celebration of life. Life celebration.
And so I told all my siblings, I said, we're already starting, Mom and I are already starting the planning of her birthday party. It's going to be at the home. It's going to be a Mexican theme because Mom and Dad used to love to go to Mexico for, for playtime. And so last year we did Hawaii. This year we're doing Mexico. And I said, come prepared to celebrate
Absolutely.
her life.
And that's one of the things that we're trying to talk to our families about. Like, why every birthday is important, right? It's our day. It's that person's day. And so make it a celebration. I mean, this is a time to be happy, and let them plan it. Let them have some, say and a voice in that. How awesome is that?
Yeah.
I am really big in celebrating birthdays, and like I said, doing celebrations of life when people are alive, to celebrate their lives with everybody that is important to them. So kudos to you, because that is definitely something I feel very strongly about.
Yeah. Now let's shift gears a little bit. So we've talked about, living, your best life possible day to day. There will be a time when, I'll use my mom as an example, where she will be bedridden. She will be so weak and tired that she cannot get out of bed. Talk a little bit about the stages. I don't know if you're prepared to do this, but if you can, talk a little bit about what goes through the last moments of somebody's life. And I think that's an important conversation to have, because it helps to prepare us. And it's also a part of the natural process of accepting death that we're all going to face at some place, somewhere along the line. And we're all going to experience it a little bit differently. Right. I understand that. I've seen many, many people pass. My dad passed in my arms. My grandfather passed in my arms. I'm assuming my mom will pass in my arms, assuming I'm here, if I'm that fortunate. But there's a process. Explain what that looks like.
So, and I think if I would go back and say the myths about hospice is that they don't eat anymore. If your loved one is referred to hospice and they're not eating anymore, like on day one, they were not referred soon enough. I do think that somebody can be mobile like your mother and then not get up out of bed, stay in bed longer. Maybe their appetite starts to decline, and then it ultimately will diminish. Just like we don't feel like eating when we have an illness, right? Cold, the flu. That happens when somebody is transitioning, as we like to call it. So the three big things that I always say to people when they call, or even friends, because I think once your friends know that you're involved in hospice or any senior care, you then become the expert, whether you have any business being the expert or not. They call you and I'll say, oh, okay, well, have they ate today? And they'll be like, well, just a little bit. I'm like, okay. Have they drank anything? Yeah, they're still drinking, just not eating. I go, okay. Are they still going to the bathroom? Yes. You've got some time. Now, what does time look like? Time isn't months, might not even be longer than a week, but I would always say that those are signs that the body is slowing down. And I always then reiterate what we know. There's a misnomer that they're going to have hunger pains, that they're going to, dehydration is painful. And I think that, I always like to reiterate that studies have shown that, there's a euphoria that goes kind of on when somebody hasn't ate. They're not in any pain if they stop eating. They're not in any pain if they stop drinking. And so, just really kind of let them look for those things. So when you're with your mom, ask the staff how many times she went to the bathroom. Really focus on not so much the food, but the drinking, of water. And just kind of spell out kind of those steps that lead us to believe that they are going to pass away sooner than later. So, I mean, there's always respiration. There's always the use of pain medicine. Do they look more anxious? Are they more anxious? Are they having to use routine pain medications, whereas before they were using them as needed? I think those are all the things that kind of paint the picture that somebody is transitioning towards, death and passing away versus maybe being as stable as they once were.
And then is there bodily, so like when my dad passed, I mean, he was gurgling, what they call gurgling. Explain so that somebody that is with their loved one, that they're not going to panic and they're not going to, and how you approach that whole thing.
Yeah, and I think that is where that hand holding by the nursing staff of the hospice team really has to be visible. And they really have to make sure that they understand what the dying process looks like for this particular patient and where they are in that process. So definitely, the rattling, the gurgling, we may have to use suction. We may not have to use suction. There's different smells that occur. There's, sometimes wounds develop, so just really educating that family as to this is what you should expect. Let's not hide, because deaths can be angelic and they can be very calm and peaceful, but there also are deaths that you can do a lot of things. You can do everything right, and they're still very hard to be a part of and to watch. Yeah. I saw that firsthand. And so I think, and I'll say I'm not a nurse. I know enough to be dangerous, certainly, but, there's certain things that the body is telling you, that the organs are shutting down, the respirations are slowing down, the breathing, the gurgling, the smells, the urine output, all those things paint a picture that, yes, we are nearing this person transitioning and passing away.
And this is where you talked about earlier about being observant, observe and then report. So pick up the phone, call the hospice team so that they can come in and provide the kind of support that they're trained to do.
Yeah. And I read a lot of just different notations for our team, and it is constant education provide about what next steps look like, what the process looks like, what to expect in the next couple days. If you aren't educating your families before those things occur, and then as they're occurring, you're really missing the boat. Yeah. You're really missing how impactful you can be, because there is really no reason why a family should be going into a death blind without having, now, every death looks different, but they should have a little bit of information that they can feel like, oh, Nurse Terry told me to expect this. Nope, I talked to my nurse the other day. She said probably in the next couple of days, be looking for these things to occur. That's when you've done your job to relieve that family of fear and really chaos. So I hope that there's a lot of conversations going on around the bedside about what to expect.
Yeah. And I think that's where, your motivations, or what is it that drives a hospice team. And I think that from my perspective, life is sacred.
Absolutely.
And if you don't have a team around you that doesn't believe that life is sacred, you've got the wrong team, because they're not going to have the compassion to walk you through those steps and to make this an angelic experience for not only the the individual, the patient, but also for the family.
It's the why, right? You were given the privilege of taking care of them at the most imminent stage. And it is a privilege that should not be taken lightly. And if you aren't kind of doing all those things that we just discussed, then to me, you're not mission driven about what right hospice looks like.
Yeah.
And it is a sure way that you won't be in business any long, because the families are going to be the ones that brag about what Nurse Terry did to make their experience better. And sometimes their experience is theirs that they're
Yeah.
talking about. Maybe not so much mom or dad. So I really think that every resident, we can be impactful for what right looks like when they need it most.
Yeah. And I think bringing it full circle, we started out the conversation with caregivers, and every hospice team member is a caregiver.
Right.
And if you're a transactional caregiver, you're going to miss the boat, especially when it comes down to hospice. You've got to be relational, and you've got to look at life as being sacred. And you have to have a perspective of that social awareness and that presence.
Yeah.
And that is such a simple thing, being present. But I've seen and witnessed many, many hospices that are not present. And that's sad.
That's
that
something
being
else
said,
we can't say what that is, but that's just
yeah,
it's not it. It's
yeah,
just
that's
not
that's not it.
It's just not it.
Yeah, yeah. So anyhow, that I think, coming full circle, I think that's where we need to probably leave this conversation. Absolutely. Unless you have something else that you want to say in particular. No. But I think it was a great starting point. Obviously, there is more to the onion that we could unpack layer by layer. But this is a great conversation, and I hope that many that were listening will begin to ponder and ask all the difficult questions. And a great place to start is your physician, but maybe not. I mean, right. Not all physicians get it. Not all physicians, because they're more what we talked about, curative. So, but there are a lot of resources out there. And are there any resources that you could share with the rest of us that you found to be inspirational or impactful in shaping your vision of what hospice should be?
I mean, so yeah, there's a lot of great national hospice palliative care associations out there. When we went through our accreditation, we learned a lot from those organizations. Podcasts like this help us, understand what's out there. We're in the Midwest. What else is going around in the country. Sometimes you think you're so fast and a mover and a shaker, and you realize that somebody else has been doing the same thing for 10 years. So I really think really checking out your local palliative care and hospice organizations in your state as a provider. But if you're like a potential family member that needs help, maybe ask. It's not so much that doctor that may have the right resources, but I for sure know their nurses usually know who to refer to and who to ask questions for, or sometimes they have case managers in the physician group. But really, my only final thought is, and sometimes as providers, we're the worst for our own families, but to really lean into what's hard. And sometimes what hard is to sit down with mom or dad and ask, what are their wishes?
Mm-hmm.
What is concerning? Tell me how to handle this, mom, if this were to happen. Do it before the chaos starts, because it's a lot easier to take care of mom or dad's wishes when there's no chaos and know that they've told you exactly what to do versus the opposite. So, lean into what's hard, and really, hospice isn't hard. Hospice is a gift.
Yeah,
that
absolutely.
Everybody should be able to have.
And if somebody wanted to get in touch with you, what's the best way to do that?
Sure. So I'm with Friendship Village. So my email is Zerban, Zerb as in boy, AN, Stacey STACEY at F as in Frank, V as in Victor, STL.com. You can look up Friendship Village St. Louis, Google us, and we'd love to hear about your story or help someone out that needs some direction.
All right. Stacey, what a pleasure to have you on and to meet you
Thanks
finally.
so much.
And
Yes.
let's do it again, because like I said, we've only touched the surface of what is hospice care. And I think that there's so much more that we can talk about.
Yeah, I look forward to this not being our last conversation, Mark. So thank you so much for having me.
All right. And this is Mark Turnbull, your host, and I want to thank all of you for tuning in to Aging Today. We are the podcast where together we're exploring the many options to aging on your terms. Join us every Monday when we release a new conversation on Aging Today to your favorite podcast channel. And remember this, we're all in the process of aging, and as we age, we really are better together. So stay young at heart.
You make me feel so young. You make me feel like spring has sprung. And every time I see your face, I'm such a happy individual. The moment that you speak, I want to go play hide and seek. I want to go and bounce the moon just like a toy balloon. Well, you and I are just like a couple of tots running across the meadow, picking up lots of forget-me-nots. So you made me feel so young. You made me feel there are songs to be sung, bells to be rung, and a wonderful fling to be flung. And even when I'm old and gray.
You've been listening to Aging Today, where together we explore the options to aging on your terms. Join Mark and his guest next week for another lively discussion on proactively aging on your terms, connecting you to the professional advice of his special guests, with the goal of creating better days throughout the aging process. Your host has been Mark Turnbull. Join Mark and his guests every week on Aging Today, your podcast to exploring your options for aging on your terms.
And even when I'm old and gray, you make me feel the way I feel today. 'Cause you make me feel so. You make me feel so. You make me feel so young. So young. You make me feel so young. You make me feel so young.